Hey, Kevin.
Hey, Sean.
I think Aswaria has joined as well.
Okay, perfect.
Hi.
Hey, how are you?
Hey, Rory, how are you?
Good.
So I've shared with Sharon our suggested leads on the questions, so she's great with that.
Great. Excellent. And then we'll just give people a couple more minutes and then we'll start. So why don't we get started, everybody? So good evening and welcome to another vaccine town hall. Really pleased to have you join us. And I'm Sharon Strauss. I'm a geriatrician researcher and based at St. Mike's. I'm also chief of medicine at St. Mike's. And we're really excited to have two infectious disease experts with us tonight who are going to answer the questions. And I know that several of you emailed questions in advance. And then I would also ask you to use the chat feature. So we have Dr. Aswaria Manoharan, and she is an ID resident here at the University of Toronto and is just finishing up her training and has got lots of expertise in the COVID pandemic and also in regards to the vaccine. And we also have then Dr. Kevin Gough, and Kevin is also an ID physician, division head of infectious diseases here at St. Mike's, which is part of Unity Health Toronto, and is an associate professor in the Department of Medicine. And both Kevin and Aswaria have led town halls before, and we have shared the questions that several of you have provided in advance. And as mentioned, please feel free to put additional questions in the chat feature and we'll monitor that and we'll direct them. And also wanted to also acknowledge Aswa, who organized the town hall for us tonight. And thanks so much, Aswa, for everything that you've done to keep us on track. So to start off, one of the first questions that people posed is, what are the variants of concern and what do they mean? And Kevin, I thought maybe you could start off with that one.
Okay, sure. So I thought I'd combine variants and mutations because there were two questions around that. So viruses mutate all the time. So viruses are generally made up of clumps of genetic material, either DNA or RNA, that's covered by protein on the outside. And in the case of COVID, it's this spike protein that we've all been hearing about. So once the virus gets into your body, usually through your nose or your mouth, it attaches onto one of the cells, and its sole purpose in life is to reproduce itself. So if it gets into your cells, then the DNA or the RNA reproduces itself, makes copies of itself, and then goes on to infect another virus or another cell in your body. And if the virus is able to hijack enough cells in your body, then that's when you become sick, if your immune system isn't able to control that replication in the cells. But every now and then, when the virus goes into a cell and it replicates itself, it makes errors when it's copying itself. And there's a lot of specific particles that need to be lined up in a specific way, and sometimes errors happen. And those errors are called mutations. So it's a mutation in the virus. Most of the time, it doesn't cause a problem at all. The virus doesn't notice it, or sometimes it actually makes the virus weaker and it's not able to replicate as well. But once in a while, a mutation can happen that can allow the virus to cause infection better in the body. So it allows it to attach to cells better and allows it to replicate inside those cells better. So when this happens, then the virus thinks, this is a good thing. I'm able to reproduce more often. So it incorporates that mutation into its normal genetic makeup going forward. And when the virus you started out with incorporates this mutation into its new makeup, then it becomes a variant. And so basically, variants are a new strain of virus that come about by the process of mutation. And so what do we know about the coronavirus variant? So mainly there are small changes in this spike protein that allows the virus to attach to cells and then enter the cells and to cause infection. And so far it looks like the variants are allowed to be transmitted more easily, and they can also cause more severe disease in people who are become infected. So these mutations they've hung on to because it's helped them to survive. And so the answer really to preventing these mutations and therefore variations is to reduce the amount of virus that's floating around in the community, in the world, that is allowed to grow and to replicate itself and to cause these mutations. So a really good reason to receive the vaccine is to prevent that transmission from person to person and not give the virus enough time to replicate and therefore mutate and therefore become a variant.
Great, thanks so much, Kevin. And related to that, people wanted to know how effective are the vaccines against the variant? And Iswari, do you want to answer that one? Oh, you're on mute.
There we go. That's a great follow-up question. And really, initially, when we had just started vaccinating people in other countries like the UK and the US, initially there wasn't much information out there about the efficacy of these vaccines against the variants, but several months have passed now that we've seen that we've had experience now, I suppose, with these variants, specifically the UK one, which is the predominant variant that's found in Ontario these days. And we know from the information that we have out of the UK and out of other countries that started vaccinating on a larger scale earlier than Canada, that these vaccines do offer protection against the variants, especially the UK variant. And I believe more information and more research is coming out about some of the other variants, including more recently the Indian variant. And I believe just last week or something like that, data from Pfizer came out saying that it does protect against the Indian variant as well.
Great, thank you. Kevin, so there was a couple questions about scheduling for the second dose and about some of the changes in that process. And I wondered if you can speak to, first of all, are there exceptions to the current second dose extensions? And then how do people find out about that?
Right, okay. So the exceptions, I mean, this is all determined by the provincial government. So there have been exceptions to second dose extension. So the government, for reasons that in terms of getting more vaccine to more people earlier, extended the interval to 16 weeks for the doses that were studied, even though the studies show sort of 21 and 28 days between the doses. So the reason for that was they wanted to get more vaccine out to more people to reduce the amount of virus circulating in the community for reasons, some of the reasons that I just talked about, but to prevent people from becoming seriously ill from the virus. But there are certain groups that don't respond as well even to the single dose. So the government has looked at some literature and some results that were presented to them and decided that there were a few populations that would be exempt from this. And one would include transplant patients, so people who receive organ transplants or stem cell transplants. And the reason for that, so they recommended that they get it at the 3 or the 4 week mark, whatever was recommended by the manufacturers at the clinical trial. And the reason for that is that they don't seem to respond as well to the first and single dose of a vaccine. So whereas Other people may have a vaccine response rate of perhaps 80% after the first dose. The people who have received transplants, either solid organ or stem cell transplants, don't receive that. And they're often suppressed, immunosuppressed for an extended period of time. And in the case of solid organ transplants, indefinitely for the rest of their life. They're immunosuppressed, so if they happen to become infected, they would have much more severe disease. They were also found to have higher viral loads or higher amount of virus in their secretions and mucous membranes, et cetera, so they could transmit more easily to other people. So for these reasons, people who were transplant recipients were given the second dose as scheduled. The other group that was included in that were those people with certain types of cancers, blood cancers and solid tumors, if they were receiving active chemotherapy treatment. And the reason for that was, again, like the organ transplant recipients, they didn't respond as well to a single dose of vaccine. So they weren't getting that same benefit as people who didn't or who were not immunocompromised. And it was found that if they got a second dose after 3 weeks, they responded better. So for that reason, people with malignancies who are actively receiving chemotherapy were included. And then more recently, the government has included people who are more likely to be coming face to face with persons who are infected with COVID. So healthcare workers who are working with COVID patients, lab personnel who are doing testing in the lab, first responders, as well as essential caregivers at long-term care residents were being allowed to book a second dose sooner than the 16 weeks that was marked. So those groups were included. And interestingly, age initially and currently has been excluded. So older adults, it was found that even though they didn't develop as strong an antibody response, it appeared that they were still benefiting from that first vaccination in terms of preventing spread and reducing the risk of serious illness and hospitalization. So that group, the group of older adults, was not initially included, but I have it on good authority that that may be changing as more vaccine supply becomes available.
Thanks, Kevin. And just related to that, somebody asked about, and you alluded to this, about why is the vaccine guidance changing all the time, and why does that happen?
So the initial recommendation of 16 weeks was so that more people could receive that first dose of vaccine. So we know that after the first dose, the efficacy or the protection is around 80%, which is quite good. And the second dose kind of boosts that a little bit higher and extends the duration. But the first dose is very effective. So because there is a global pandemic, and to increase access to vaccine to as many people as possible, the government made a decision to extend the interval required for the second dose out to 16 weeks. It was based on some data that were available at the time. So some trials showing that the first dose did provide a significant amount of protection, and also sort of looking at our experience with other vaccines that require multiple doses. So as I mentioned, the first dose of the vaccine usually gives the majority of the protection, and then the second or subsequent doses increases that protection slightly and then extends the duration of that protection. So for example, we see this with hepatitis B vaccine, for example, which is 3 doses of vaccine. So putting all of that together, we're trying to get vaccine to as many people as possible from a public health perspective, and also looking at some efficacy data of how well a single dose worked and looking at what happens with other vaccines. That decision was made. I expect that interval, and we're starting to see it happen now, that interval will shorten as the vaccine supply increases. So in an ideal world, we would give it just as how it's shown to be most effective in the studies, but until that time, for public health reasons, it was extended. But I think that interval will decrease as more supply becomes available.
Great, thanks, Kevin.
Yeah.
Ms. Warrior, one of the questions that came up is, if I had COVID, do I still need to get the vaccine?
So To answer that question, the guidance that we've been providing patients is that even if they've had COVID previously, that we would still recommend that they get the vaccine. And the reason that we say this is because, number one, research is still continuing to come out about how much natural immunity is produced by natural infection with COVID-19. And certainly we've seen that in patients who've had asymptomatic infection or very mild infection, that they don't, in all cases, mount as robust an immune response as one would like. And really right now, it's still unclear at this time how long you're protected against COVID-19 through natural infection. I think most recently we have had some studies come out that say that, in healthcare workers who've had mild disease, that they do have evidence of antibodies even 6-8 months after their infection, but that doesn't mean that those antibodies will persist longer or that they might necessarily guarantee protection against COVID-19 again. The other thing is that with these variants, it's unclear how much your natural immunity protects against these variants, whereas we do have research to suggest that these vaccines will offer protection against many of the circulating variants. So that's another reason to get the COVID-19 vaccine as well. I don't know if Kevin wants to add anything to that.
No.
And then related to that, Iswaria, if they did have COVID, how long do they need to wait before they get the vaccine?
So we typically say that patients should not get the vaccine while they're actively symptomatic or infected, and that we would wait until they're considered recovered. So once they're asymptomatic, they're finished their period of isolation. And then after that, if they're feeling well, they can go get it. There is not a particular timeline that we would recommend, but at the minimum, once they've recovered asymptomatic and finished their isolation period, they can go and get their vaccine.
Yeah, that's a really good point. You don't want to be going to a vaccine center while you're still infected. So that's come up a couple of times. But yeah, I think that's great. And part of the reason too is that we don't want to confuse symptoms of the vaccine with COVID and COVID symptoms with the vaccine. So as Iswaria said, it's best just to wait until your symptoms have resolved and then go get the vaccine. There are some people who are, the term is long haulers, or people that have symptoms of COVID that persist after the usual symptoms. So it may be ongoing fatigue, for example. That is not a reason why you can't receive the vaccine. If that's the case, then you would go, because some symptoms don't resolve in the usual sort of 14-day time period that we're used to. So those people can go on and get it.
Thank you. Kevin, there's a question from Joyce saying, is corneal transplant affected by one dose of the vaccine?
I'm not sure how to interpret the question. Is it, can you receive the vaccine if you've had a corneal transplant, or can you have a corneal transplant if you've received the vaccine? Probably the latter, I'm thinking. I don't think it would be. I'm not sure what's involved with the corneal transplant specifically in terms of medications that are given to suppress your immune system. I think it would be okay. I'm just not familiar enough with what's involved with the corneal transplant. I would suggest touching base with the ophthalmologist around the transplant, but I don't imagine it would be a problem. But I don't know the details of the medications that are received, for example, in that setting. But it might be that you don't respond as well if there's any element of immunosuppression. But I would suggest checking with the ophthalmologist.
Can I say something? Hello?
Yeah.
Hello?
I had a corneal transplant done August of 2020 because of a hereditary complaint. Everything is okay with my eye. I had my first dose of Pfizer on March 22nd. So far, I don't seem to have any problems, but I just want to be sure.
Yeah, I don't think it would be a problem. I'm happy to sort of take it offline because I would have a few questions about the current medications you're taking and that sort of thing, which we don't need to discuss here. But I wouldn't anticipate a problem. But if you'd like to submit a question through the organizers, I'd be happy to look into that and get back to you.
Okay, I'll do that.
Okay, thank you.
Yeah, that's
Thank you. Yeah, so feel free to use the email that that you use to submit questions, and then we can link you up with Kevin after this.
Thanks also for answering my questions on the mutations and the variants.
Great, thank you. So Iswaria, one of the questions that that has come up related to what we were talking about before, about if you do have COVID, do you need a COVID test before you get the vaccine?
So the answer to that is no. Really, there's no need to get a COVID vaccine unless, number one, you're symptomatic or you've had a higher risk exposure to someone and you'd like to get tested. And we say usually in that case, 7 days after your exposure, go get tested. In that case, if you're still asymptomatic, but certainly before getting your COVID vaccine, there wouldn't be any particular reason to get a COVID test, especially again, if you're asymptomatic.
Great. And just as a reminder, feel free to use the chat feature to post your questions. So, and we'll continue to monitor that. Thanks, Iswaria. Kevin, there's a lot of questions around the AstraZeneca vaccine, and in particular, some people who had the first dose want to know, should they get the second dose?
Okay, so, and there was also a question around blood clots. So maybe I'll combine all this into one response. So currently, Ontario is offering the AstraZeneca vaccine for the second dose. The first dose is on pause because of risk around the blood clots. So the current recommendation is, if you've received the first dose of an AstraZeneca vaccine, to receive the second dose as well, unless you've had a severe reaction to the first dose. So the blood clots in general, I'll start with that and then make my way through the AZ vaccine. But the risk of blood clots with the first dose now in Canada is estimated to be somewhere around 1 in 83,000. So the incidence has increased as more and more people are receiving the vaccine globally. But for Canada, it's thought to be about 1 in 83,000. And after the second dose, which is what you would be asking about here, the numbers are still being collected, but it appears to be much smaller and somewhere in the order of 1 in 600,000. So it is a much smaller risk of getting the blood clots. So far, NACI, which is the National Immunization Committee, National Committee on Immunization, is recommending that making recommendations around holding off on switching vaccines, and I'll talk about that, and recommending that the current, if you've received it the first time, you receive it the second time as well. And you've noticed that the government this week has offered it at 10 weeks instead of 12, which is also a bit confusing to some people, and it's because they've got some vaccine supply that's about to expire. So they're offering it 10. So the recommendation is to receive the AstraZeneca number 2 if you've received it the first time, after having sort of a risk-benefit discussion around what are the risks of blood clots, and is that sort of acceptable to you based on your personal circumstance. So the next question that comes out of that is, well, should I hold off until I can get one of the mRNA vaccines, so the Pfizer vaccine or the Moderna vaccine? And the answer to that is sort of complex, in that it depends on what the likelihood of you being infected with COVID, because we know that the risks associated with COVID infection can be much more severe, including serious infection, hospitalization, and death. So a number of points were recommended to consider around, should you get the other vaccine first? So how much COVID is there, in your community? And so if you're in a hot zone, there's a lot. So that would increase your risk of exposure. What is it about you personally that might increase your risk? So do you have other comorbidities that if you became infected, would you have more serious disease? And what about environmental factors, like your workplace, for example? Are you able to, physically space in the workplace? Do you have access to proper PPE? And then the question that we really don't know, which also needs to factor in, is when will the mRNA vaccine be available to you? So when can you get a Pfizer if you choose to hold off and not receive the AstraZeneca right now? And we don't know the answer to that, but all of those things need to be considered when you're making a decision about whether to receive the AstraZeneca or defer to try to receive one of the other ones. So if you've received your first one, consider those. The risk of blood clot is much lower, but it's real. That needs to be considered as well. Which vaccine is better? Is this a time to roll into that one, or?
Yeah, sure.
That was another question that we got as well. So what we do know that all vaccines sort of are effective in the short term. So they all offer protection against hospitalization and serious infection. And even AstraZeneca and compares with the Pfizer and Moderna approaching 100% in preventing that. So they all do that, prevent those major outcomes. So that's an important thing to do. You may have heard, and why this question might have come up, is that the NACI recommended or suggested that the mRNA vaccines are preferred. However, they say in the next breath that the AstraZeneca vaccine may be given, considering all of those things that I just talked about. And the reason why they say it was preferred was because of this risk with blood clots as more and more information is coming to light about it. So I wouldn't say there's a preferred vaccine if you're aware of the efficacy, and which are very good for all of them in terms of preventing hospitalization and serious adverse effects, and also have considered the risk of blood clots for your personal situation as well. So I don't think there's a best one, but there are things to be considered.
And just to follow up on that, Kevin, there was a question around the Janssen vaccine and people wanting to know kind of, should they wait for that one because it's only one shot? Any thoughts on that?
Yeah, so the Janssen vaccine, I mean, we know that it's on hold now in terms of release in Canada because of some manufacturing issues at the plant in the US where it was manufactured. In terms of the efficacy, it's somewhere in the order, from the clinical trials, somewhere in the order of 66, 67% or so. It was actually a bit higher, that's overall. It was about 70, just 70 something in the US. But then when it was studied in South Africa, where there was a variant of concern emerging, the efficacy was lower at 57% or so. So more data need to come out about that. Does it match up to AstraZeneca and the others? But so far we don't have those data. And the other question that might come up is around blood clots. So there are blood clots with the Janssen vaccine as well, because like the AstraZeneca vaccine, it's one of these viral vector vaccines, as they're called. So far, looking at the numbers out of the US, I think they've given well over 9 million doses, and there are about 30 episodes of clot. So it appears to be a much lower risk of developing blood clots, but it does happen with that as well. And again, it appears so far to be mostly in younger women, but don't forget that's how AstraZeneca started out as well. And as more and more data become available, it happened to affect men and women and of older ages as well. So I think we need a bit more information about the Janssen vaccine. Knowing what happens with Health Canada and vaccine approval, I'm fairly confident that they will have gone through these data with a fine-tooth comb before it's licensed and offered in Canada. So they did the right thing by, I think, halting approval in Canada when it was determined that there were problems with the manufacturing plant in the US. And now, in the meantime, looking at the data from the UK and the US and other jurisdictions where it's been used, how effective is it and how safe is it? And we'll have more information, I think, about that before it's released in Canada. So far, it's a non-issue because it's not available, but it's a great question because it likely will be.
Great, thanks so much, Kevin. Iswari, there were a couple questions again on whether it's okay to get the vaccine, first of all, if you're pregnant, and secondly, if you're breastfeeding.
Sure. So I think we had a very similar question during the last town hall as well, and it is something that comes up fairly frequently with respect to whether pregnant women can get COVID-19 vaccine. The Society for Obstetricians and Gynecologists of Canada has come out very clearly saying that they very much support the decision of a pregnant woman to get the COVID-19 vaccine. And as we've seen during this most recent wave, there have been more pregnant women who've ended up in the hospital, and several who've had to go to the ICU and require ventilatory support because of COVID-19 infection. And in fact, the numbers support that as well. I think anywhere between 7 to 10% of pregnant women who acquire COVID-19 infection end up requiring hospitalization. And these are, for the most part, young, healthy women without any other comorbidities. So we do think it is pregnancy that is acting as a risk factor for their more severe disease. And so for that reason, as I said, the SOGC very strongly supports vaccination during pregnancy as well as during breastfeeding. The other thing that I should say with regards to the question of safety, there's been quite a bit of post-vaccine surveillance data that's come out now from patients who are either pregnant at the time of vaccination or became pregnant afterwards. And so far, no adverse events have been reported in this population, which is good news. But as we continue to get more population data, we'll have more information to sort of confidently say, yes, it is safe. But at this point in time, what we can say is, although there's no data to suggest safety or efficacy in pregnancy or breastfeeding, we have not seen any adverse effects, and we know that the benefits of getting the COVID-19 vaccine outweigh any hypothetical risk, especially now that we've seen more pregnant women end up quite sick in hospital and in the ICUs. And the other question I think that came up was also whether the COVID-19 vaccine was safe or with respect to conception and whether it could cause infertility. And really, there's no reason to think that it would have any impact on fertility. It's not a live vaccine. It's, these mRNA vaccines, again, are not live vaccines. There's no reason to suspect that they would have any role to play with respect to, first or second trimester pregnancy loss or any congenital anomalies. And certainly the SOGC, again, recommends COVID-19 vaccination in women who are also looking to conceive.
Great. Thanks so much, Iswari. Yep,
Can
Kevin.
I just add to, so I mean, that's a great question. Iswari mentioned there's around the conception. It's a really good idea. There's stuff going around social media, and it was sort of misinformation or disinformation about that. Much like, did Bill Gates put microchips in the vaccine to track our every movement, that kind of thing. So it's funny where there's maybe a little bit of truth in something around Bill Gates being involved in, donating money to the vaccine, but it gets spun into these crazy things. And that's what happened with the infertility piece as well. So Iswaria nailed that. I mean, that's exactly, it's just totally not true. One thing to add about breastfeeding too, is that women who are breastfeeding who've received the vaccine, they have antibodies are found in breast milk. So that may provide some protection for the baby. So that still needs to be determined, but that would be another benefit, potential benefit as well.
Excellent, thank you. Just as a reminder, if anybody wants to post questions, please use the chat feature. So another kind of safety question. One of the participants asked, can I just ask everybody to mute? Iswaria, if people are allergic to bee stings, can they still get the vaccine?
So the Canadian Society for Allergy and Immunology has come out saying that in patients who have had even severe reactions to animal bites or stings, or severe food or environmental allergies, there is no reason that they cannot get the COVID-19 vaccine. They've come out very clearly and said that. And in patients who may be allergic to components of the vaccine, such as PEG, even for those patients, they don't give a hard contraindication to receiving the vaccine. Their recommendation is that these patients be referred to an allergist and immunologist for a more detailed conversation around the actual reaction, and to consider the possibility of even doing something like a graded administration of the vaccine. So from their perspective, even in patients who might be allergic to a component of the vaccine, that in and of itself is not a contraindication, and they would just recommend a consultation with an expert in order to further discuss that. And I would recommend, if anyone had questions about the components of the vaccine, or questions around allergies, if you just visit the Canadian Society for Allergy and Immunology and just type in COVID-19 vaccine, they have an excellent patient FAQ that goes over all of the more commonly asked questions around that as well.
Great. Yeah,
to add one comment, and that's where I don't know if you were in a vaccine clinic, but Sharon and I were vaccinating, and one of the questions that we asked before you get the vaccine, you're always asked again about your allergies and if you've had a severe allergic reaction as well. And I know in my group, I did have some people who used an EpiPen because they did have severe allergies. And we talked about that risk. Some had spoken to their allergist, some had not. But just know also that when you're in the clinic getting vaccinated, for people who have had a severe allergic reaction, instead of the usual 15 minutes, we keep people for 30 minutes. And there are personnel and medications there to respond to an emergency if you happen to have a reaction. So it's part of the question before you get the vaccine. And then if you do have a slightly increased risk because of your allergies, you're kept for longer, and there are always people there to help you.
Excellent. Thanks so much, Kevin. And related to that, any comments on how commonly allergic reactions have been happening after the vaccines? For either one of you? How common how common are we seeing allergic reactions after the vaccine?
Oh, I don't know, do you have a number, Swearia, of what?
Not off of the top.
They're uncommon, they're very uncommon. I don't know the exact numbers, but they're not like the usual local reaction for sure, but severe reactions are very uncommon. There were just a couple initially reported in the UK that were serious. And since then, there are very few. I mean, they do happen, but very, very uncommon.
And Kevin, one of the questions that came up was, will I need another booster vaccine? So after I get a second dose, a few months from now, will I need another one?
Yeah, that's a really good idea. The short answer is we don't know. So far, people that have received the first one will be followed, or the first series, if you will. So 2 doses, if it's a 2-dose vaccine, are being followed to see how long a couple of things, the antibody level persists, but then what does that mean in terms of protection? So it's too early to know for sure. And then the other thing that has to be factored in is that we now have variants of concern that are emerging. And then the question is, will the current vaccines be effective against these variants and newer variants if and when they emerge in future? So that remains to be seen. I know that some of the companies are working on a booster that includes some protection against variants that it didn't have in the first version of their vaccine. So the vaccine manufacturers are responding to these variants as well. So the short answer is we don't know, because it's too early to see how long the immune response lasts against kind of non-variant virus, but also if new variants emerge, that may affect the efficacy of the vaccine in the long term as well. And we might need a booster or perhaps a vaccine on a semi-regular basis every 1 or 2 years or so, like the influenza vaccine, which changes annually. So that remains to be seen.
Great, thank you. Victoria asks, have there been any incidents of reactions to the vaccine in persons who have asthma? And so is asthma a contraindication to getting the vaccine? Ms. Wari, do you want to answer that one?
Sure. So in and of itself, no, asthma would not be considered a contraindication to getting the vaccine. And in fact, we would want patients who have asthma to get the vaccine because they are at a slightly increased risk of getting more severe infection as well, especially given the fact that they have underlying lung disease. So I would say that, you know, I would hope that their asthma is controlled and that they're not in the midst of some sort of episode or anything like that. But if they're, you know, if they're feeling well and they're not feeling unwell at all, just having asthma in and of itself is not a contraindication to getting the vaccine. And I would highly recommend that they do get it.
Thank you. And Kevin mentioned some of the side effects, but Swaria, do you want to speak to the commonest side effects from the vaccine?
Sure. So as Kevin was mentioning, the most common one is sort of a local reaction with soreness, sometimes a bit of swelling and redness at the injection site. That typically will happen a few hours after you get your vaccine. So usually we say get it in your non-dominant arm because it will feel sore. And anecdotally, I found that the response to the first dose has been quite variable. For myself, for example, I just had a local reaction and nothing else, whereas I've had friends who had fevers, chills, muscle aches, even after the first dose. Whereas for me, it was the opposite. It was after the second dose, you know, a couple hours or 12 hours afterwards that I started to get those. And those would be the other more common symptoms. So fever, chill, muscle aches, just general malaise. And again, that's just the vaccine doing its job, right? That's your body building its immune response to the COVID-19. And really boosting your immune response against the virus. So it's not something to be alarmed by. And in terms of the symptoms, how long they last, I would say anywhere between a few hours to sometimes up to 2 days. And so I really, you know, the side effects are very similar to what would happen with a flu vaccine for anyone who's had the flu vaccine before as well. Those would really be the most common ones, I would say, yeah.
I have to laugh because after my second dose, the only thing I did, I had the best sleep of my life. So I slept for about 10 hours. Now I was probably exhausted, but that was the only thing that I had at the second dose. So yeah, I wish I could get it every day. But then I went and I looked, because the thing that people say is, well, does that mean that it's not working for you? Like you should have a response you should have symptoms so that you know your immune system is responding to the vaccine. And that's not necessarily the case. So even if you don't have a lot of symptoms or side effects afterwards, it doesn't mean that the vaccine's not working for you. So I had a big sleep and I feel protected. That's great.
So excellent. But clearly, Kevin, you're working too hard. That's why.
Or it was the vaccine that gave me a nice sleep. But either way, I enjoyed it.
Exactly. I just wanted to follow up on a question that was posed, and Kevin, you spoke a little bit about the approval process, but people were wondering about how did the vaccines get developed and approved so quickly? Because it seems that, you know, in some cases, it almost seems like countries were kind of caught off guard in terms of having a vaccine already ready to go. And can you speak to that? Were there any shortcuts that happened?
Right. So that's a great question, and it's on a lot of people's minds. So I guess there's no doubt that these vaccines were developed quickly. And the question is, as Sharon said, were corners cut? And the answer, in my opinion, is no. And why is that? Well, the technology that was used to develop these vaccines, so this mRNA technology, has been used for 10 years or more. So it's been used in studies of vaccines, in human studies, the vaccines of different viruses like Ebola and CMV and things like that, and also used in cancer therapeutics. So that mRNA method, that platform was ready, available, and ready to go. And there were a lot of people, a lot of scientists who had a good experience using that platform. So that took off right away. There were a lot of really smart people around the globe who were cooperating and collaborating to make this happen, because this was affecting the whole world and we wanted to get this under control, or the vaccine researchers wanted to. So everybody was sharing information, sharing ideas, sharing resources, that sort of thing. There were at one point at least 160 different vaccines being studied. So the more vaccines are being studied, the more likely there is to be a successful candidate. And lo and behold, there were several to date, and there will likely be more again in the future. The other is around the approval process. So looking, the way that clinical trials are normally done, they're done in phases. And before you move on to phase 2, phase 1 must be complete. What does that mean? You have to look at all of the data, make sure everything is safe, make sure everything is done, and then you move on to the next phase and so on. So studies of drugs and treatments can take 7 or 8 years normally. But in this case, they did things on sort of a rolling basis where the data, the information from this subsequent phase, the second phase or the third phase, was being looked at as it was coming in before the preceding phase was done. So they were looking at phase 3 information before phase 2 was complete. But by the time the vaccines were licensed, every single piece of information from every phase had been looked at, and it was made sure that the vaccine was both effective and safe to be given. So it did happen very quickly, no doubt about it, but corners weren't cut in the process. I mean, people just really worked together to do it. And the example that I think about is when you remember in China, they built a 1,000-bed hospital in 10 days in response to their, to this pandemic. So that is unheard of, but it happened. And it's still standing. So if you put resources, people, money, time into a task, it's amazing what can be done. And that's what happened with this whole vaccine process. So I feel good about the process. And, I was right up there with everybody at the beginning. This happened way too fast. What's going on? I need to look at this. And I remember, going through all the numbers, going through the process, and, satisfying myself that it was safe to stick in my arm. And that's what I did.
Excellent. Thanks, Kevin. And I think your point around just kind of worldwide, the collaboration that went on as a result of COVID, I think it's just been remarkable, like whether it's the vaccine or, or intervention studies, I think it's, sharing data, I think it's just been a silver lining.
Hopefully it'll be the new norm, right? That's how things will progress in future. So that it was actually, the silver lining, as you said.
So excellent. Iswaria, one of the common questions that comes up is, do we still need to wear a mask if I get the vaccine? And certainly in the US, we're starting to, they're ripping the masks off. And do you want to speak to that?
I won't speak too much to what the US is doing, but
smart.
But certainly from our perspective in Ontario and Canada, we are still recommending that even in patients who've been fully vaccinated, people who've been fully vaccinated, that they do still continue to practice the appropriate physical distancing, keeping 6 feet apart and using masks in sort of contained areas. And the reason for that is because we still haven't reached what we would call herd immunity. We still haven't quite reached that point yet. And there are patients there are people in the community who, for certain reasons, may not have received the vaccine yet, who may not be able to receive the vaccine, or who are at higher risk of acquiring, of getting severe COVID-19. So really, by wearing our masks and doing our due diligence, we're also protecting those in our population who haven't been vaccinated yet. And the reason I say that is because although research does show that vaccination not only prevents infection, it does to some degree prevent transmission as well. We just simply don't know to what degree. And so out of an abundance of caution and to sort of protect the rest of our community, I think it's important to continue practicing all of those hygiene practices, physical distancing and masking for now, until we've, in the future reached a point where we've reached herd immunity, or where we as a community feel that it's safe to sort of start peeling back on that. One thing I will say that I think will probably continue going forward is the practice of wearing a mask when you're having symptoms. We've certainly seen a remarkable reduction in flu rates. Basically, flu has been non-existent for the past year and a half that we've had COVID-19. And it really does speak to the fact that proper hand hygiene, masking, not coming to work when you're sick, things like that do work. And so I think in the future, I suspect we'll probably continue to see that going forward, that the idea of masking when you have symptoms or not feeling well will continue going forward. Yeah.
Great, thank you. So we're just about 10 minutes away from 8. Are there any other questions that people wanted to pose in the chat box? We'll give you one more minute if there's anybody who wants to pose a question. And just, if not, then I'm going to ask Iswari and Kevin just to kind of the final comments, and anything in particular that we didn't talk about that you wanted to make sure that people were aware of. So Iswari, do you want to start off? Any kind of final comments, tips, suggestions for people?
I mean, beyond the fact that I would recommend that everyone who hasn't been vaccinated yet, who's eligible to be vaccinated, I would highly recommend that they do get it. I think Ontario has made tremendous strides within the last couple of weeks to try and get as many people vaccinated as possible. And, you know, we are starting to see the benefits from that, or we're beginning to anyways, certainly seeing a reduction in the number of cases across the province, the number of hospitalizations and admissions to the ICU. And again, I think that just goes to show that this intervention is working. And really, the sooner that we get everyone vaccinated, fingers crossed, the sooner we can all go back to normal or a new normal, whatever that may be. And so, yeah, like I said, go get vaccinated. Vaccines are becoming much more easily accessible these days, and we're getting lots more shipments of vaccines as well. So really highly encourage everyone to get vaccinated when they can.
Thanks. Kevin, final comments, thoughts?
Yeah, I would just add to that, that, you know, what I alluded to this earlier, when these vaccines first came out, you know, like everybody, I had my doubts, my questions, you know, my concerns, but, you know, I think the way to approach that, and part of that is what's happening tonight, is to reach out with questions and get the answers that you need to satisfy yourself that it's the right decision for you. And everybody has different questions and different levels of comfort with risk or with taking vaccines, but get the answers you need so that whatever your decision is, and I hope it would be yes, that you've made the decision based on information that's correct and you've had all of your questions answered. But there are really very few reasons why the vaccine can't be given, and it basically is severe allergic reaction to one of the components. Otherwise, everybody should be eligible to receive the vaccine. And so I would encourage you to get the information you need and to make a decision that's great for you, because that's how we're going to get this under control. And as Iswari said, get back to normal, but also reduce the risk of circulating virus and more mutations and more problems down the line. Let's get rid of this sucker.
Exactly. So so it looks like there's one more question, Victoria. There are some videos circulating in social media with people saying that at the vaccination site, a magnet will stick to where you got the vaccine. Is there an explanation for this, Kevin?
Wow. So you mean like on the arm where you got the vaccine? Okay. Maybe it's the microchip. So I don't know. So no, there isn't any. It's interesting. So it's a really good example. I haven't read that, and I'm going to look it up after I get off of this call. But I haven't read that. But to me, it sounds like another example of misinformation or disinformation, even, that's being circulated out there. There's nothing metallic in the component that would make a magnet stick to your arm. It may be related to the thought of the microchip that was implanted by Bill Gates that I talked about earlier. Maybe that's what the thinking is. Maybe there's something in there, but there is absolutely no truth no rational explanation to that that I can think of. Much like the fertility question that was brought up, much like the microchip, and now this one. And I will look it up after we're off this call. And if I learn anything helpful about that, I'll pass it along to the organizers. But I suspect that it's more misinformation.
Thanks so much, Kevin. And just in final wrap up, thanks everybody. It's we're just short of 8 o'clock, so we're bang on time. So thanks so much everybody for your participation. Thanks in particular to Iswaria and Kevin. Just really a fantastic amount of information that you provided with us tonight. So thank you so much. For the participants on the Zoom call today, if you go to the wellnesshub.ca website, there's some additional vaccine information, including a vaccine infographic that's available to that you can have a look at as well. And the email address is also posted in the chat box if you wanted to follow up with any questions afterwards as well. Thanks again to everybody. Thanks to OSWA for organizing us, and again, thank you so much to Iswaria and Kevin. Have a great night, everybody, and be safe and get vaccinated.
Yes. Bye.
Bye. Good night.